Hi, good day, everyone. I would like to thank the organization for inviting me to speak on this talk on the updates in fungal diagnostics. And I'm Yen Yi from the Singapore General Hospital. I have no financial disclosure of note. And these are the content of my talk today. An introduction of the invasive fungal infections, IFI in short, and the challenges and gaps in the fungal diagnostics. The overview of the fungal diagnostics since the current status, as well as some of the enhancement and expansion of applications, and the newer development on the fungal diagnostics, and I'll end with some conclusions. So invasive fungal infections have emerged as a major cause of morbidity and mortality, especially among the immunocompromised, such as in the hemato-oncology groups. And Candida species remains one of the top 4 in the bloodstream infections, such as in the ICU settings. The overall mortality rate remains high, with a 40 to 50% mortality due to candidiasis and a 30 to 70% mortality due to aspergillosis. The rate of pre-mortem diagnosis of IFI remains at about 50%, and hence rapid and accurate diagnostic kits are required to improve the patient outcomes. What are some of the challenges in fungal diagnostics? Fungi can be a colonizer, pathogens, or even from environmental contamination, and hence vigilance is required in the interpretation of cultures, especially from the superficial, as well as the PCR test. Most of the time, the clinical manifestations are non-specific, and the collection and the type of specimens are crucial in the interpretation, whether it's a superficial culture versus a deep collection. The direct examination or culture from sterile sites are the gold standard. However, these conventional diagnostics are insensitive with late positivity, and blood cultures are only able to pick up 50% of the invasive candidiasis. And in July this year, there was an article published in JCM trying to recognize the diagnostic gaps for the lab diagnosis of fungal diseases. It's a good paper, and a group has actually been formed. It's known as the Fungal Diagnostics Laboratories Consortium, FDLC in short. And in this committee, they recognize some of the gaps in the current scene for fungal diagnostics, which are highlighted with the red box. And I'll attempt to touch briefly on some of the points later on in my talk. So before I move on, just a quick reminder of the diagnosis of IFI. It's not just a laboratory investigation, but it's also heavily rely on the clinical features, the host factors, as well as the radiological investigations. So for the diagnosis of IFI, the current status, I summarized briefly into 3 parts. One is the histopath methods, the culture-based methods, as well as the non-culture-based methods. Just 1 or 2 slides on the histopath methods, because it's still essential to note that in the new EORTC MSG definition updated in 2020, it's still part of the criteria for proven invasive fungal disease for sterile material. And the EORTC stands for the European Organization Research and Treatment Cancer and Mycosis Study Group. And not only will the histopath slides review the morphology of the fungi, but also help to review the architecture of the tissue response, such as the tissue invasion or whether there's any inflammatory reaction. And this helps the pathologist to determine whether the fungi is due to a contamination or colonization or true infection. And of note is that there's also immunohistochemical stains that are available that can help us to identify certain fungi, such as Aspergillus and Rhizopus. Moving on to culture-based methods. So culture-based diagnostics, they are generally slow and insensitive and may need more than 4 weeks of incubation. They require considerable expertise for identification, and it requires a sporulating culture to identify filamentous fungi phenotypically. However, culture enables isolates to be retrieved, and it allows antifungal susceptibility testing, ST in short, to be performed, and even strain typing when needed. In recent years, there have been enhanced techniques in the fungal culture, such as the use of screening plates like chrome agar as well as MALDI-TOF. A slide on chromogenic media. So recently, in the recent years, there have been more and more selective and differential plates for mycology, and one of them is the chrome agar Candida Plus, And this allows the differentiation of Candida auris, which is a multi-drug resistant fungi. And this helps in the laboratory greatly in helping to screen the C. auris in a more rapid manner. Moving on to MALDI-TOF, and I'm sure most of the audience here knows what is MALDI-TOF MS. It stands for Matrix Assisted Laser Desorption Ionization Time of Flight Mass Spectrometry. It has been part of the routine workflow from most clinical diagnostic labs. And this technology involves two key components. One is the efficient protein extraction and the database. And there are two commercial systems currently that are FDA approved in the market, and these are the Bruker as well as the Biotech MS from BioMiro. The advantages of MALDI-TOF is simple, rapid, and reproducible. It helps to reduce the cost and turnaround time, and it helps to identify the common yeast with high accuracy. However, the disadvantages for mycology is that the database is still pretty much limited, especially for the filamentous fungi, because of a lack of standardization for culture and extraction. Further, this is complicated by the changing taxonomy in mycology. Also, there are significant capital and maintenance costs required, and this needs a backup plan if the machine breaks down. In the mycology setting, most laboratories use it for yeast identification for common fungi, and in some laboratories, they use it for mold identification when they have built their own in-house database. In other literatures, it has been listed yeast identification from the blood culture directly, as well as to detect, predict resistance, as well as subtyping. So in general, MALDI-TOF serves as a gap between the conventional culture as well as the molecular methods, and is faster and cheaper if you have the database. And moving on to the non-culture-based methods. So generally, the ideal test should be rapid, sensitive, and specific. Sensitive enough to pick out early clues as a screening tool, and specific enough to diagnose and confirm the disease in patients with the signs and symptoms. And I've listed down the pros and cons of these non-culture methods. The pros are that it offers a rapid turnaround time. It is not dependent on viable organisms. It may be positive before the culture turns positive and may remain positive during therapy. It may offer increased sensitivity, especially the PCR-based method. And it may combine with the detection of markers for drug resistance. However, the cons are that it do not recover organisms, and hence no ST can be performed phenotypically, may not distinguish between fungi, may need to be run in batch due to limited specimen numbers, and they may have a low threshold for contamination, and of course, cost is always a factor. I would like to broadly even further classify this by the antigen as well as the DNA component. So for the antigen-based assays, is widely used for the IFD diagnosis. It's commercialized, faster than culture. However, that depends whether the laboratory practice batch testings, and sometimes it's transport dependent. And some kits may provide quantitative results. The first thing I'd like to introduce is this lateral flow assay or device, LFA and LFD in short. It utilizes the immunochromatography technology, and it allows the diagnosis within minutes. It serves as a point of care testing and is easy to perform as affordable. And I would like to touch briefly on the Cryptococcus, Aspergillus, as well as Histoplasma Lfd and Lfa. For Cryptococcal antigen lateral flow assay, it improves the microbiological diagnosis of Cryptococcosis greatly. It detects the capsular antigen of neoformans as well as Gatii, but is unable to differentiate between these two. It detects in the serum, the CSF, and the urine, and can be qualitative or semi-quantitative. It requires no heat enzyme treatment at room temperature, and the result is ready within 10 minutes versus 2 hours as compared to the previous technologies of latex agglutination. And it offers a serial dilutions of up to 2560. It's an FDA-approved kit since 2011, and a meta-analysis involving more than 4,000 samples showed the following pooled sensitivity and specificity of a near 98%, which is very good for a kit. I'd like to touch briefly on Aspergillus lateral flow device and assay. And currently, there are two commercial LFD and LFA available in the market, and they are the ASC Aspergillus Lfd from the OLM UK as well as the EMI Sona Aspergillus GM Lfa from the USA. These kits help to diagnose invasive pulmonary aspergillosis, IPA in short. It offers a fast screening test because of its short turnaround time, but confirmation if other diagnostic tests are still warranted, such as galactomagnum, GM in short, PCR, and culture. I've attempted to summarize in the table form, and the OLM is the UK is on the left-hand side, and the EMI from the US is on the right-hand side. Both kits are CE marked with the EMI pending FDA approval. One is the lateral flow device and one is the assay. For the OLM, it uses a JF5 monoclonal antibody to detect an extracellular glycoprotein antigen that's secreted by actively growing Aspergillus species. The EMI uses 2 monoclonal antibodies to detect against the Aspergillus GM that's differ from the OLM. OLM is only able to be used in the serum and BAL, while that of EMI can use in all samples. Both kits require pre-treatment for the sample except for non-bloody and non-viscous BAL, in which OLM does not require any pre-treatment. For OLM, the incubation time is 15 minutes. For EMI, it's 30 minutes. And both kits, you can be read by a naked eye or by visual reader. And both kits also reacts with some fungi as listed in the table. The meta-analysis of serum for the sensitivity is 68% and the specificity is 87%. That of the BAL is 86% for sensitivity and 93% for specificity. So you can see that the BAL performed much better than the serum, and both assays actually demonstrated good performance for the diagnosis of IPA from BAL specimens in the hematology population. And hence the LFA may serve as a role that may replace the conventional GM testing in settings where GM is not readily and rapidly available. So in the 2017 guideline from the ASME ECMM ERS guideline of a diagnosis of Aspergillus species, it was stated that given the strength of recommendation of B and the quality of evidence of 2, it recommends BAL LFD, and we are expected to see an increasing role of these kits in the IA diagnostics. Moving on to the Histoplasma Lfd and Lfa, again, there are 2 commercial kits available in the market. One is the MiraVista and one is the Optimum Imaging Diagnostic, OIDX in short. And both kits allows the rapid detection of disseminated histoplasmosis. Again, I attempt to summarize in a table form. And both kits detects the histoplasma capsulated antigen. And for the MiraVista, it can detect it from the serum and urine, while the OIDX only from the urine. Both have good sensitivity and specificity as listed, with a MiraVista of a sensitivity of 92%, specificity of 94%, performed in the AIDS population using an automated reader. And from an internal evaluation by the OIDX, it was stated that the sensitivity is 96% with a specificity of 89%. MiraVista requires a longer time of 30 minutes, while OIDX requires a shorter time of 15 minutes. And both kind of cross-react with some form of endemic fungi as shown in the table. Just a slide on this Alice spot for mucorales. This is not readily available because more studies are needed. However, in some literature, it was mentioned that this Alice spot, which stands for enzyme-linked immune spot assay, it helps to detect the mucorales specific T cells in the blood, and these are involved in the clearance of the infection and are associated with proven invasive mucormycosis. Moving on to the next antigen test, beta D-Glucan, and this is present in the cell wall of the fungus in majority of the fungi, except for Mucor, Rhizopus, Cryptococcus, and the east phase of Blastomyces. Of note, it is also absent in the bacterial, virus, as well as mammalian cells. There are currently 5 commercial assays in the market, but there's only one FDA approved and CE mark, and that is Fungitel. And the EORTC MSG ERC guideline last year updated and included this beta D-Glucan in the diagnosis of probable IFD in certain clinical settings. And that includes the hematology population with or without neutropenia, as well as those following a stem cell transplantation. The second group is the ICU patients following a gut surgery with a higher risk of invasive candidiasis of more than 10%, those with a recurrent leaks, perforations of the upper gut, or necrotizing pancreatitis. And the threshold cut-off for the Fungal test is more than 80 picogram per ml. And it's only for serum with some success with CSF, and the confidence will increase with repeated positive tests. And again, in the 2017 guideline, it gives a poor ranking for this beta D-Glucan for the screening of invasive aspergillosis with an overall sensitivity of only 46%, as the data suggests that it is unsuitable for ruling out diagnosis of IA, and confirmation with other tests such as GM is required. And these are a list of other factors that can cause a false positive taken from the product insert, such as in the hemodialysis patient using certain blood products, as well as certain surgical gauze that contain glucan, and certain antibiotics such as cephalosporins and carbapenems. And hence, galactomannan remains an important role in the diagnosis of IA. It's a gold standard biomarker. It's present in the Aspergillus cell wall, also in the penicillium and histoplasma. It can be detected in the serum, BAL, urine, and CSF. And the kit is a biorat test, Petelia Aspergillus ELISA. It's FDA approved and also included in the EORTC guideline. And these are the revised guideline last year. Different threshold for different specimens, and this can be applied to both adults and children population. To note is that the revised threshold is different from the manufacturer, which is 0.5. And exposure to more active antifungals will reduce the sensitivity of this test. The 2017 ASMIC guideline gives a high ranking of A1 with a good accuracy of when 2 or more consecutive samples show a result of more than or equal to 0.5. However, there's also cross-reactivity with histoplasma, fusarium, as well as tularomyces. Moving on to nucleic acid-based tests, a key test that not only helps to complement the culture methods, but also has a primary diagnostic method. It is useful to identify fungi that lack distinguishing morphological features, such as non-sporulating mold, culture negative but histo-proven infection, as well as species within a complex in terms of outbreak settings. It also has its own sets of limitation and consideration. And in the 2020 EORTC guideline, it has included the pan-fungal PCR as well as the Aspergillus PCR into the criterion. The pan-fungal PCR recommends that pan-fungal PCR and DNA sequencing on formalin-fixed tissue only be performed when fungal elements are seen by the histopathology. And this helps to guide in the antifungal therapy when the culture is negative. However, cautious in the interpretation is contamination, whether it is within the specimen itself, by the master mix, or by the environment. And it's not recommended for non-sterile sites, including BAL, because of the fact that it may amplify commensal fungi, such as Candida species. The last one I'll mention is Aspergillus PCR, and the Fungal PCR Initiative, FPCRI Consortium, has developed a criteria for Aspergillus PCR to harmonize the method. And the advantage is that it's rapid. It may help to differentiate species in some kits and detects resistant markers. Again, the disadvantages are false positives due to contamination or colonization, and the expertise in the molecular settings are required. The indication is largely divided into screening or diagnosis, and many studies performed in the screening for IA from the blood is from the hematology settings. You can see that when 2 positive PCRs, the sensitivity dropped to 57.9, but the specificity increased to 96.2. So assuming a mean prevalence of IA of 13%, if we use 2 positive PCR to define a PCR positive, there's a good NPV of 94 to 96%. And this means that a negative test result is able to rule out IA with a little need for antifungal treatment. And for the diagnosis of IA from BAL, CSF, and tissue, again, unable to distinguish between colonization or infection, moderate recommendation by the European groups. However, a negative PCR is useful to exclude IA. And again, this is the guideline from the recent 2020 EORTC, which you can find out more from the paper last year. And there's the kit available in the commercial setting, which is known as Aspergillus. However, this is costly. The Canada PCR has also been in the market. However, it's currently not included as a criterion in the defining invasive candidiasis because of a lack of method standardization. However, the FPCRI is developing a standard. Other drawbacks is similar to the Aspergillus Pcr, and that includes high cost and a false positive results. There's a test kit in the market known as a T2 Candida system that's FDA approved. It combines a targeted PCR with T2 magnetic resonance using whole blood. And there's also a T2 CORIS panel, but this is only under a research use only platform. It has good sensitivity and specificity. However, it has variable PPV. And therefore, the cost effectiveness is highly dependent on the prevalence of the candidemia in the institution, including with the cost of antifungal therapy as well as the test reagents. The pros and cons are largely similar to other PCR platforms, but to highlight is that this platform can only detect the 5 most common Candida species, and it cannot differentiate between albicans and tropicalis and vibrata from crucei. And also about 20% of candidemia patients will have concomitant bacteremia, and hence bacterial culture is still needed. The last, I just touch a bit on the newer developments in fungal diagnostics. And this involves metabolites. So you can detect the antigen, the DNA, and now the metabolites of the mold. And this is an emerging methods for the disease diagnosis. There will be articles to show the novel cutting edge for the metabolite-based tools for aspergillosis. So not only can it detect the various metabolites listed, but also the volatile organic compounds, VOC in short, and changes to the host metabolome in serum. And to make it easier, there's even an easier platform known as an electronic nose, whereby you just need to detect the metabolites in the human breath, which is very non-invasive, fast, and cheap. The last one is this immuno-PET MR imaging. This is a non-invasive detection of Aspergillus fumigatus lung infection using antibody-guided PET and MR imaging. And it allows a specific localization of lung infection when combined with PET imaging, and helps to differentiate Aspergillus from the pneumococcus and other bacterial pathogens. So in conclusion, no test covers all the fungi and the combinations are needed, but this requires cost. Culture still plays an important role in the diagnosis for morphological correlation and susceptibility testing. Non-culture tests are important adjuncts, and they play an increasing role in fungal diagnostics, but vigilance is required in the interpretation and always correlate with clinical and radiological findings in high-risk patients. And there are novel developments on the horizon, detecting the metabolites as well as pathogen-specific imaging. So with that, I'd like to end my talk, and I welcome any question. Thank you.
So there's a question from the audience. This is whether has there been any plans or ongoing collaboration to build an in-house national Maori database for Singapore?
Hi, thanks, Shuwei. No, there isn't any current plan to build any national library, but within SGH, we are doing a pilot among ourselves because it requires a standardizations, and I understand that different labs have their different methods of extraction, and sometimes even the media culture inoculation.
Okay, so just another question from me pertaining to patients with prolonged febrile neutropenia. Do you think there's any advantage over screening of the serum galactomannan versus the PCR for invasive aspergillosis? When would you prefer one over the other?
Well, I guess I guess PCR has an increasing role, but having said that, not many I'm talking about in Singapore setting, not many laboratories offer Aspergillus PCR. So galactomannan still remains the gold standard. And I think that, again, depending on your institution protocol, whether you're like more preemptive or prophylaxis, then you determine the frequency of the monitoring using the galactomannan. But if there is an Aspergillus PCR, of course, a combination of tests maybe even better, will give the clinician a better confidence.
Okay, thank you very much, Yan Yi, for your time.